What happens when your body's ultimate defense system gets confused and launches a friendly fire attack on your own nerves? Well, let's dive into this explainer on Guillain-Barré syndrome and other immune-mediated neuropathies. We're going to be breaking down the exact molecular targets that dictate a patient's clinical presentation, and honestly, more importantly, their treatment. For anyone looking to truly grasp how the peripheral nervous system falls under autoimmune attack, this right here is the masterclass.
We have a ton of ground to cover today. We'll hit 1. GBS and molecular mimicry. 2. GBS triage and treatments. 3. Chronic inflammatory demyelinating polyneuropathy. 4. Nodal and paranodal autoantibodies. 5. Multifocal motor neuropathy. And finally 6. Vasculitic neuropathies.
All right, Part 1, GBS and molecular mimicry, the pathogen's disguise.
So, you might be wondering, how does this nightmare actually begin? Well, GBS is often preceded by an infection. In fact, up to 30% of cases are linked to a bacteria called Campylobacter jejuni, and it happens through a fascinating process called molecular mimicry. Basically, the surface glycolipids of this pathogen actually mimic our own neural gangliosides. It is the ultimate biological disguise. Because the pathogen is essentially wearing the host's uniform, it completely tricks our immune system into launching a cross-reactive attack against our very own peripheral nerves. And the result of this on a cellular level is absolutely catastrophic. Autoantibodies bind to the nodal axolemma. This binding acts like a tripwire, triggering the complement cascade and forming the membrane attack complex, or MAC. You can really just think of this complex as a cellular wrecking ball. It summons macrophages to the site, which then actively scavenge and destroy the injured myelin and axons. It's a highly targeted, highly destructive breakdown of the nerve's conduction pathways. What's wild here is just how specific this autoantibody targeting actually is. The exact ganglioside being attacked entirely dictates the clinical variant the patient is going to experience. For instance, the acute motor axonal neuropathy variant, or AMN, targets GM1 and GD1A. But take a look at Miller-Fisher syndrome. It's definitively linked to anti-GQ1B antibodies. These heavily target the extraocular motor nerves, which leads directly to its hallmark presentation of ophthalmoplegia, ataxia, and areflexia.
Moving on to Part 2, GBS triage and treatments, arresting the acute attack.
GBS is a descriptive entity, and its clinical presentation demands immediate, rapid recognition. Patients typically show up with a rapidly evolving, ascending, flaccid paralysis and areflexia. The progression generally plateaus within 4 weeks. Now, to map this out reliably in the clinic, we use the validated Brighton collaboration diagnostic criteria. These guidelines firmly require bilateral weakness, areflexia, and a monophasic illness pattern, all while ensuring absolutely no other alternative diagnosis exists. To really confirm that clinical suspicion, we have to look at the cerebral spinal fluid. By the end of the first week of symptoms, a lumbar puncture will uniquely show something called cytoalbuminologic dissociation. It's such a fascinating paradox. You see a massive spike in protein, but without the expected swarm of white blood cells. Specifically, it keeps the count under 50 cells per microliter. This tells us right away that we are dealing with nerve demyelination rather than a direct active central nervous system infection like a viral myelitis.
Once GBS is identified, the clock is literally ticking. When it comes to treatment, the huge takeaway here is that you must choose either IVIG or plasmapheresis immediately. They are equally effective at reducing the need for mechanical ventilation, but crucially, never, ever combine them. It provides zero added benefit. Oh, and completely avoid glucocorticoids because the data has firmly shown they are entirely ineffective for typical GBS.
Let's jump to Part 3, chronic inflammatory demyelinating polyneuropathy, the smoldering fire.
Now, the timeline here is absolutely critical. Both GBS and CIDP share electrodiagnostic findings of acquired demyelination, and sure, both have elevated CSF protein. However, CIDP is completely defined by its protracted timeline. If the condition keeps progressing beyond 9 weeks, or if it demonstrates a relapsing and remitting clinical course over months, you are no longer dealing with typical GBS. You are definitely dealing with CIDP.
And this extended timeline completely changes the game pathologically. This ongoing, vicious cycle of chronic immune attack, followed by the body's desperate attempt to repair the myelin, leads to distinct histological changes called onion bulb formations. Think of them almost like tree rings. They're a physical testament to the relapsing chronic nature of the disease, completely visible on a nerve biopsy. And here is a key difference. Unlike GBS, because of this chronic inflammatory state, CIDP actually uniquely responds to glucocorticoids.
All right, part 4, nodal and paranodal autoantibodies, precision medicine.
So when is CIDP not actually CIDP? This is where the medical detective work gets really fascinating. We used to lump a ton of these chronic cases all together. But it turns out about 10% of patients previously diagnosed with typical CIDP actually have a distinct condition called a nodopathy or a paranodopathy. And identifying this, it changes absolutely everything about how we manage them clinically.
We're talking about very specific targets here, things like CNTN1, NF55, and Caspr1. They are primarily mediated by Ig4 isotype antibodies, and why does that matter so much? Well, because Ig4 antibodies do not trigger the typical immune cascades, these patients generally have a really poor response to standard IVIG therapy. Recognizing this early allows us to make the crucial switch to B-cell depleting therapies like rituximab, which can dramatically alter their prognosis for the better.
Part 5. Multifocal motor neuropathy, asymmetric attack.
Getting this specific diagnosis right, it is literally a matter of life and death. Multifocal motor neuropathy, or MMN, presents as an asymmetric motor-only weakness. Because of that specific presentation, it can frighteningly mimic the lower motor neuron signs of ALS, which is obviously a fatal neurodegenerative disease. But by performing an EMG and finding a persistent focal motor conduction block, he proved it's actually MMN. It's an immune condition driven by anti-GM1 IgM antibodies that is highly treatable with IVIG.
Finally, part 6, vasculitic neuropathies, systemic collateral damage.
With systemic vasculitic conditions like polyarteritis nodosa or Churg-Strauss syndrome, the nerves actually aren't the primary target at all. Instead, the vasa nervorum, those tiny little blood vessels feeding the peripheral nerves, are choked off. It's devastating collateral damage, causing widespread ischemic nerve death, and it often presents as a mononeuropathy multiplex. To save those nerves, you have to aggressively treat the underlying systemic vasculitis using robust immunosuppressants. We're talking glucocorticoids combined with cyclophosphamide or rituximab.
As we wrap up this explainer, I really want to leave you with a final thought. We've seen how distinct autoantibodies, from GQ1B and Miller-Fisher all the way to CNTN1 in the neuropathies, demand entirely different therapeutic approaches. Identifying the exact molecular target completely dictates the clinical intervention. So as our molecular mapping gets even sharper and more precise, it forces us to ask, how soon will the days of relying on broad, generalized treatments like IVIG be completely behind us, replaced by a new era of absolute precision neurology? Think about it.